With beginning of use of laparoscope in 1970, breakthrough in surgery and investigation procedures occurred. Though it was rather tricky to master a laparoscope by surgeons, it was good for patients in many ways. But soon it became clear that laparoscopic intervention was not free from complications and limitations. The biggest problem arises where prior adhesions were present in patient, either due to previous surgery or due to some pathology like septicemia, Cox abdomen, or malignancy. The usual working port for laparoscopy is through umbilicus, but in cases of previous adhesions, this entry port is not good because adhesions usually occur in para-umbilical area, midline, upper part, and almost whole right side of abdomen. Therefore, the quest for non-umbilical entry port began, and thus several entry ports were suggested. For example, Palmer's point, Li Huang point, ninth intercostal space point, etc. We will look at the situation of these entry points very briefly. In 1974, R. Palmer suggested a point named after him. This is Palmer's point, which is in mid-clavicular line, 3 centimeters below the costal margin in left hypochondrium area. This is Li Huang entry point, midway between Xiphoid process and umbilicus. And this is ninth intercostal entry point, and it is in anterior axillary line in ninth intercostal space in left side at the superior border of the rib. Apart from this, there is one open Hassan technique where blunt trocar is introduced through umbilicus with vertical incision and a pneumoperitoneum is created. All these points were used and they mitigated the problem of laparoscopic surgeons in cases of previous adhesions. But these points too were not free from complications and there were contraindications to use them. For example, there are several contraindications of Palmer's point. For example, hepatosplenomegaly, portal hypertension, gastropancreatic mass, huge gynecological mass, type 2A adhesions due to infective pathology like septicemia or Cox abdomen. Then in 2022, after 11 years of research with 8,586 patients with previous one surgery or more than one surgeries, Dr. Jain and her associates recognized and suggested a new non-umbilical entry point for laparoscopic surgeons. We will discuss about this very substantial study in some detail in this short documentary. But first let us see where this point is situated, which is known as Jain point now. Jain point is a point for non-umbilical entry situated in left part of abdomen. The exact situation is the meeting point of two lines. One horizontal line from lumbar 4 vertebra level or umbilicus level and another which is a vertical line beginning 2.5 centimeters medial to anterior superior iliac spine. In adults, the horizontal line is 10 to 13 centimeters long and the vertical line is 10 to 12 centimeters long. Jain point is quite lateral in its position and this area is free from adhesion. It is quite far from lower pole of left kidney and upper part of sigmoid colon, and it is safely distant from mesenteric artery and the superficial epigastric artery. Jain point is the point of choice for entry port in laparoscopic surgery where adhesions are present and a non-umbilical approach is required. Dr. Jain and their associates collected data of 8,586 patients who underwent laparoscopic surgery in her center from January 2011 to March 2022. So the number of subjects are too large and time span is quite big in this research. Gynae and general surgery cases have been taken for this research. The patient's age, history and operative notes were carefully recorded. Patient's BMI, indications of surgeries, mode of surgery that is open or laparoscopic, incision of previous surgeries, complications, alternate procedures than planned one, delayed discharge, intraoperative complications, complications up to 2 weeks after surgery, all were recorded, including a follow-up for incisional hernia. To avoid false inflation of data, cases of patients with multiple surgeries were counted only once when tabulating data for mode of surgery and type of incision. For instance, if a patient had undergone laparotomy with right paramedian incision and a caesarean section with phalangistic incision, only the right paramedian incision was considered because the probability of having paraumbilical adhesions is more with this type of surgery and incision. 48-hour low residual diet is given to patient before surgery. Mechanical bowel preparation was done except in emergency cases. Many procedures in the study group have been done, notably ectopic pregnancy, tube ovarian mass or abscess, and torsion of ovary. General anesthesia is given in dorsal lithotomy position. Entire abdomen was inspected and the previous incision sites were noted. Abdominal wall is not lifted, avoiding unequal forces and zigzag track. Layer by layer entry was done. Same technique was applied for obese or thin patients. Varus needle is preferred and it entered perpendicular to the skin. 2 pops were heard as it crossed aponeurosis of external oblique muscle, fused aponeurosis of transverse abdominal muscle and internal oblique muscle. After crossing these points, a resistance is felt as needle enters in peritoneal cavity. With proper safety precautions, pneumoperitoneum was created and a 5 mm trocar and telescope is inserted. Area below entry point is checked for any injury and then 360-degree check for abdominal cavity was done, especially upper part of the abdomen at Palmer's point area and below diaphragmatic region for any adhesions, scarring and the location of adhesions were noted. Then 10 mm telescope is entered at an adhesion-free area. Jain point provides a working distance of 10 to 12 centimeters, which is quite ergonomic. General and neurosurgeons also have used this point as camera port or working port in the course of surgery. The result of this study is spanning 11 years and 8,586 cases highlight the safety of Jain point as a routine entry port in previous surgery cases. However, paper is restricted to 2,519 patients, in which 2,121 cases were of gynae surgery and 398 patients are of general surgery. Among gynae cases, which were 2,121, 1,168 were laparotomy and 953 cases were laparoscopic surgery. Among 2,121 cases of gynecology, lower segment cesarean section is maximum. But if we leave LSCS, the maximum laparotomy was done in ectopic pregnancy and the maximum laparoscopic intervention was done in endometriosis and pelvic infections. Out of 398 patients of general surgery, 186 patients or 46.7% cases were laparotomy, 212 patients, that is 53.26% cases were laparoscopic procedures. Maximum cases were of appendicectomy and cholecystectomy. The distribution of laparoscopic surgeons were as follows. 34.68 entry were made through Jain point by senior consultants, 33.14% by junior consultants, and 32.16% by fellow surgeons. The demographic profile of the patient, such as BMI, number of previous surgeries, type of scar, indications of previous surgeries were taken into account. Distribution of patients according to type of scar of previous surgery were 32.87% transverse scar, 16.95% vertical scar, 1.98% McBurney's, 1.75% Cocker's scar, 46.25% lap scars, and 5% were other scars. Distribution of patients according to indications of previous surgery was found to be a very important factor to predict the adhesions preoperatively. Distribution of previous surgeries cases which were taken into this study is as follows. Previous 1 surgery was 1907, previous 2 surgeries 457, previous 3 surgeries 122, previous 4 or more surgeries 33. Only 1 case of bowel injury occurred. BMI distribution in this study shows that about 55% cases were obese, 42% cases were normal, and around 3% patients were thin, that is BMI less than 18.5. The Jain port is found safe in this study. There is no contraindication of Jain point and the risk is only 0.04%. The only limitation of this study is the fact that it is retrospective in nature. Palmer port has enjoyed many years of use worldwide by all endoscopic surgeons, but in recent years, number of previous surgeries were increased and many complications of Palmer's point entry and many contraindications emerged. For example, hepatosplenomegaly, portal hypertension, gastropancreatic mass, huge gynecological masses, scar left side, as in cases of splenectomy or gastric surgery. Even in patients with no previous surgeries, entry through Palmer's point becomes challenging in type 2A adhesions. When bowel is inseparably stuck to anterior abdominal wall, almost like making second layer of peritoneum, as in the cases of Cox abdomen and in previous septicemia. To overcome these limitations, few non-umbilical entry ports were designed. One of them is Li Huang point. Li Huang point was designed chiefly for para-aortic lymph node dissection. It is in the midway between xiphoid process and umbilicus. Though it gave some help due to its higher location and central vision, this point is not very safe. In one study of 188 cases, 2 omental and 1 colon injury were reported. There is one other approach called Open-Hessian technique. It is to remove adhesion. In this technique, blunt trocar was introduced at umbilical level through vertical incision and a pneumoperitoneum was created. But even this technique failed in type 2A adhesions. Meta-analysis of 5,284 entries which were made through Hessian technique reported 1 bowel injury, 21 infected wounds, 4 minor hematomas, and 1 umbilical hernia. Creation time for this port is long and the leakage of pneumoperitoneum gas is common. Though this analysis does not mention the BMI of patients, but this entry is difficult in obese patients. Jain point entry is in almost organ-free and adhesion-free area. It is easy to locate because anterior superior iliac spine and umbilicus both fall in sterile area of surgical field. The location taken for Palmer's point are mid-clavicle and a subcostal area in which clavicle is outside the sterile field for surgery. Jain point is good and safe for bariatric surgery, as in Jain point study, majority of patients were obese. Jain point is good for general surgeons, oncosurgeons, and urosurgeons as well. Mirror image of Jain point, that is Jain point on right side, is also useful and can be used safely without chances of liver laceration in cases where left side Jain point is occupied by some scar or drain. Unlike Palmer's point, Li Huang point, and a 9th intercostal space point, Jain point is not redundant after visualization. Jain point is acknowledged by many researchers and surgeons, including general surgeon, oncosurgeon, and urosurgeon. Watson and other observers recommended Jain point in cases of adhesions. H.T. Sharp describes Jain point as ergonomic. Einarsson et al. And Reynolds recommended Jain point when non-umbilical entry point is important. Salcido et al. Recommended Jain point in pregnant patients as Jain point is quite lateral in its position, very useful in abdomen full with gravid uterus. The safety of Jain point can be increased by using optical trocars. Charnamian threaded trocar can be used. In Jain point study, reusable trocars have been reported to be safe. Entry through Jain point is very safe. The incidence of injury to any internal organ is very less, that is 0.04%. Among 2,519 cases, only in one case, small intestine was injured, which was repaired immediately. Jain point is easy to create. The learning curve for Jain point is a steep curve. Port creation through this point consumes very less time. Even in distended sigmoid colon, adherent to pelvis, is far away from Jain point, and so is the spleen and lower pole of left kidney. In nutshell, Jain point is the most suitable entry point in laparoscopic surgery where adhesions are suspected. This point is called Jain point after the name of Dr. Nutan Jain, a postgraduate in obstetrics and gynecology from GSVM Medical College, Kanpur, India. Dr. Nutan Jain has authored several books, including 9 books on laparoscopic surgery. She is an excellent and dedicated teacher. Numerous young doctors learned the art of laparoscopic surgery working with her. She has work experience in Europe and US. At present, she is working in Muzaffarnagar, India at her own center for laparoscopic surgeries. We sincerely hope that her invention of Jain point will be very useful and convenient for all laparoscopic surgeons worldwide.